Hi, I'm Dr. Svetlana Dani. I'm a sports medicine physician in San Jose, California. Welcome to this episode of Case Bites. I'm going to delve into my case. Okay. So, my patient was a 60-year-old female. She presented with progressive right shoulder pain. Now, she had been having pain over the course of about 6 months. Initially, her pain was on and off. She would wake up in the morning. She felt like her shoulder was very stiff. She would start moving it and it would get better over the next couple of hours. And throughout the day, it was completely fine. And then by the evening, after she had been using her arm for quite some time, she started to feel the pain again. It was painful to sleep. She had to sleep on the other side. And it was painful to do things every day. Now, over the course of the 6 months, her pain did get worse, and the episodes of pain did get more frequent. And so that's why she came to see me. By the time she had seen me, she had developed some weakness and she was having trouble lifting up a heavy coffee cup. She was having trouble doing her daily activities of living. The thing that she really complained about the most was being able to do her hair. So it was very difficult for her to pick up her hair into a ponytail. And it was really those daily activities of living that were getting to her. Okay. So on her physical exam, she had very limited range of motion. Now, she actually could get through most of her range of motion. She could mostly abduct her arm. Maybe she got to 160 degrees, but it was very painful. By the time she would get to about 120 degrees, she really had to push herself. Her internal rotation, her external rotation were very limited. Her forward flexion was probably up to 150 degrees and very, very painful. Okay, so she was tender really all over the shoulder. So she was tender on the anterior capsule. She was tender on the posterior capsule. She did have a little bit of tenderness on the lateral aspect of her shoulder as well, but most of it, as she said, was really deep inside the joint space. Okay, so it felt like it was a very deep pain, and it didn't feel kind of specific to any portion of her shoulder. She developed weakness as well. It was very hard for her to do her everyday tasks. So when she came to me in clinic, the differential diagnosis for somebody who is coming in with shoulder pain is quite large. So we worry about something called osteoarthritis, so degeneration of the joint. We worry about rotator cuff tears. We worry about labral tears. Sometimes we worry about shoulder subluxation. We worry about a muscle strain. So all of those things are on our differential diagnosis, and those things vary based on age. But with an older patient, you have to keep osteoarthritis at the top of your list. Okay. And the thing that really helped us narrow down the diagnosis was her x-ray. So after the physical exam, we did obtain an x-ray, and this is what her x-ray looked like. And so if you take a look at this, you can see this is the shoulder blade right here. Okay. This is the humerus or the arm bone. This is the clavicle. Now, this is the joint space. And so when you look at an x-ray, what you should see is there should be a good space, this darkness right here, that delineates the joint space. Okay. And what you want to see is the joint space. So the space going all throughout from the very top of the joint to pretty much the very inferior portion of the joint. Okay. And if you see what we're seeing here on this x-ray, which is deterioration of that space, you can assume that that patient has osteoarthritis. Now, we cannot see cartilage, so every bone is lined with cartilage. This bone is lined with cartilage, this bone is lined with cartilage. We cannot see cartilage on an x-ray, but we can assume that that cartilage is gone if we do not see the joint space. Okay. Now, this is advanced, very severe arthritis, and she's probably had this for a long time, but when the symptoms became unbearable, when it was already in severe stages, that's usually when the patients come in. Sometimes they'll come in earlier on, but a lot of the times I kind of see it at this point. So what is osteoarthritis? I think it's good to discuss what it is. So osteoarthritis is degradation of the cartilage that lines the joint. And so, like I mentioned, there's cartilage on the shoulder blade, there is cartilage on the humerus. Now, with arthritis, and we used to think that this was just wear and tear and maybe age related, but with arthritis, that cartilage is degraded. Also, there's a lot of inflammation, and between the degradation of the cartilage and the inflammation that's associated with osteoarthritis, the patient experiences a lot of pain. Okay. Now, some of the risk factors for osteoarthritis are age, obesity. There are some genetic predispositions. So some patients tend to get it earlier, and it all depends on their collagen structure. Some patients tend to get it later, and some patients tend to never get it. And we still are trying to figure out exactly why. Okay. In some patients, you can see an x-ray of early onset arthritis. And that doesn't necessarily mean that they will get to this late stage arthritis. It just means that they have early stage arthritis, and we don't necessarily know which way they're going to go. Okay. Now, what we do about osteoarthritis is, unfortunately, it is irreversible, and it's very hard to reverse cartilage damage. And so what we really try to focus on with arthritis is we put them in physical therapy. So it's very important to strengthen the muscles around the joint that is affected. And the reason for that is because then their movements are more controlled. There's not as much stress or impact on the joint, so it's much less likely to get inflamed. And there are some injections that we can do. So we can do a steroid injection. There are some other injections that we can try. And those tend to lower the inflammation. They tend to lower the pain and make it easier for the patient to do the physical therapy and to go about their activities of daily living. Okay. We also try oral anti-inflammatory. So something like ibuprofen is very good at reducing the inflammation associated with arthritis. And then ultimately, if nothing is helping for arthritis, you could have surgery. So you could have the joint replaced. You can have a shoulder replacement. Most of the time, so most cases of arthritis by far are knee arthritis, which I don't have a picture of here, but knee arthritis affects a lot of patients, and a knee replacement is the definitive treatment for osteoarthritis. But before that, we do everything. We try physical therapy, we try injections, we try oral anti-inflammatories. There's still a lot of things that we can do. A person can live with osteoarthritis for a long time. So with this specific patient, what we did was I put her in physical therapy. I did prescribe her some oral anti-inflammatories, which were very successful for her. She did physical therapy. She did improve. After a while, she did come back. The pain was back. And so despite the fact that her strength had improved significantly with physical therapy, she was still having pain with daily activities. And so with her, we did trial a steroid injection. The steroid injection, like I said, decreases the inflammation and decreases the pain through that mean. And the last time I saw this patient, she was doing quite well. She was pain-free. She continued to do the physical therapy at home. And she does know that with osteoarthritis, unfortunately, the course is that there are exacerbations. And from time to time, she will have pain. Now, when she has pain, she knows exactly how to control it. She takes some anti-inflammatories. If she's due for it, we can do another steroid injection. But her pain is completely controlled. And of course, she has to continue to do the physical therapy throughout her, pretty much she's incorporated into her daily exercise. Okay. So that's about it. Thank you so much for listening. This was an episode of Case Bites.